this and how we conceptualize. In the first semester, it was a little like a witch hunt for some of our colleagues, but along the way they appreciated the fact that we needed to accept where we have our gaps and then embrace them and work around them so that we've addressed our gaps. The other issue is on how our system operates. You'll realize for our case, medicine availability of medicines for HIV and TB is not a problem, and even malaria. But access is where the problem is, and this has changed the way we look at provision of these services. We've gone ahead to embrace CB dots. So with our facility budgets, there is a provision for CB dots to support the DTLS and the TB champions we have in facilities to reach out to our communities. Some of the community members are unable to get to us, but we can get to them. Then it's also opened our minds to engage with our community department and actually talk to our communities about the dangers, because back in the day it's been health engaging entirely with the community. Now we've brought on board the community department. We're all engaging through the health education department. Today, on our way here, we actually came with one of our MDR patients who was enrolled on treatment, and after the first phase, he defaulted deliberately. The reason, when we interacted with him, he was telling us he had issues with the service providers at the regional referral. But of course, it's a mechanism or a technique for someone to justify why they have defaulted. Now, that goes a long way in explaining the understanding of our communities on the dangers of TB to themselves and even those around them. This is a gentleman who drinks, and someone who drinks, you know, has a higher social communication network. If they're in a drinking joint, they are probably sharing the local brew straw. How many people are actually going to carry the bacteria from him? So many. So we now take back to ourselves that we need to engage a little differently, and then strengthen community dialogue meetings. And then on our side, as the technical team at DHO's office, we need to work further and ensure that we are a little more in the facilities, supporting them to see that the services they are providing are user-friendly, but also meet the bare minimum quality of care. And then to also ensure that we have a proper linkage between our facilities and the regional referral hospital, where we might actually...
Those that require the regional or even national action or support, even national action or support. And for Buko specifically, I want to understand which additional support do districts need?
Okay, thank you. I think for what we require from the national level is improving on our infrastructure for the high volume facilities. That's the health center 4. And then having health center 3s in sub-counties that don't have. So far today, I wouldn't complain like I would have done some 7 years ago, because government has, in the last 6 or so years, upgraded another 8 facilities to health center 3s. That means we have a total of 14 facilities that can work as DTUs. Now, as much as issues of staffing are a concern at local government level and national level, I want us to agree first that if we can't optimally use the resources available at our disposal and have better use and outcomes, then it is useless to even have additional resources. And in this case, I'm talking about human resource. We have the element of organized absenteeism, which I think is the biggest killer disease for all the human resource, for every district in terms of human resource. And I ran away from the idea that I need more staff to be able to deliver. We organize our staff based on need, capacity, and also ability. We have those who know and also ability. We have those who know are very erratic. We bring those closer to us where we have a direct supervision by the MOs and stuff. What we've also done is ensure that our MOs are available for chronic care clinics, not just specific clinics. For specifically chronic care clinic, we have a standard in our hospital and health center. We have a generic duty roster. And each of the MOs by the end of the month would have spent 1 week serving the chronic care clinic. And that is a game changer. It's been difficult to have them sit there, but they have come to appreciate from the time we started integration. So it's becoming a culture.
And how are you handling their privacy?
In terms of privacy, privacy is, privacy is very generic. For my case, I know there are people who have a problem with us having one counter for pharmacy. They have a problem with that. What we've done for some of the clients whose privacy, whose condition they feel should be left private to them and we don't share with their families or another person, we've tried to create space for them to ensure they receive medication outside the bracket or the space or the common pharmacy. So we have created an avenue that allows people in chronic care clinic to have access to medication without actually going to the pharmacy, but through the pharmacy. And then for MNCH services, the issue in this case, because we had clear feedback from each of the facilities, some of the mothers were complaining that they would want to have one-to-one talks with the midwives. We acknowledge that was a mistake on our side because probably health education generic wouldn't solve some of the problems. So for those who require private conversations with the midwives, we've also indicated to the midwives to tell them that just in case someone feels comfortable having a private discussion with them, they should indicate and they can have that session with a midwife. That comes with a cost because then we now on our side as supervisors have to ensure that if it's a health center too, who have one midwife, we have to make sure that we provide a second staff support to allow continuity of service.
Yeah, thank you so much, Biostat.
Thank you for having me.
Can we hand over to Namutumba? I think he's our last panelist. And we want you to add a voice to what the Biostat has already spoken to, how you may institutionalize the CLM in Namutumba so that all our community voices are routinely heard and they can be used to inform the district planning.
Thank you, moderator. My name is Babalanda Khalif, the DC of Namutumba. However, first of all, I would like to appreciate and commend my Inshawa organization, who really gave a great representation in the House. On that issue, I wanted just to highlight on CLM. In Namutumba, CLM is taken like an evidence-based approach, which has brought together the DTH team and Inshawa as an oversight organization. For that issue, CLM is also a procedure of engaging communities. I'm trying to highlight on CLM. Then under the same umbrella, under the NDP4, under CLM, we focus on governance, public partnership, which is Namutumba is addressing under NDP4. On the issues of Inshawa, our overseer who represented and gave issues, I will comment on the structure which feeds the vacuum. CLM is a structure which fills the vacuum where the gap is. Then on monitoring, it's an integrated as well as the provision of services and constantly done in the health facilities targeted by CLMOs. That's how we monitor under that category. Then straight to the presentation by Shawa, I will comment on the concealment of information. To this, I would say every quarter, all the health facilities have community bazaars organized by OPM. So we really enter the communities. This provides an opportunity to communities to get information and receive feedback at that level about health services. Then on collusion between SHUMIC and the communities, I would rather say that all the PHC allocations are being shared with on the notice boards and any other means for accountabilities. So those were the major presentation by Nshawa. However, as a department, we have gone ahead on the institutional guidance on the communities. We always guide the communities on their roles towards the health services, because not only health workers are partly having that roles on the level of across all the services, either government or either private, either government or private. So on routine, as a department, we do the sensitizations to the communities in the implementations of the critical services like health service, mostly which is preventive. This can be through hygiene and sanitation, and we cover all that. But also to communities, we always sensitize them on the ownership of the facilities, but also the health workers, where we emphasize on the human resource in accepting them within the environment they work. Because sometimes it's a big challenge, blaming them, but also we should focus the environment in which they work. Under the NDP4, we have community mobilization and mindset change. On mindset, though gradual, we always, those whom we reach, we always mentor them in the mindset, because mindset takes some good time. People cannot, all communities cannot change immediately, but also we mentor them into appreciating the services within the areas, though on certain times they resist somehow because of the attitudinal mindset or change. Still on accountability, you see now communities always need physical accountabilities. They don't issues of information, soft information, they will not appreciate, but they always require physical accountabilities. We always take on them to appreciate all that. Then on the mode of communication, that's really where we are, because now the challenge is between the health workers and the other stakeholders. How do you communicate the services which are affecting the communities through the facilities? Sometimes there are issues of crude communication, but we always handle and guide these communities how to accept and also look at the that relative issues which may cause trouble. Then on the denial, always communities are always denying. However much they know something, if you call them here like this, you gather. One of the participants informed us here, government activity taking on now. However much you inform them on services, sometimes they deny.
Yeah. We appreciate. I'm certain that you, as you listen in, there's really a lot Ishawa has for us this afternoon. And we are looking forward to see on how we can institutionalize CLM so that the voices of the communities are taken up in our district planning. Very, very critical. Members, in the interest of time, join me thank the panelists.
Madam, I had one issue lastly.
Yes, please.
It's on the disability issue. I'm getting a lot of challenge in my facilities in Namutumba, where issues of disability are not being handled well. The reason is we have failed to, as in Namutumba, to recruit an interpreter or sign language. It's a big issue where we as a committee department, like on issues of GBV, when in our referral path, when we refer those cases, you may find that the health workers may don't critically analyze the issues of vulnerability because of they lack the sign language and the interpreters in their facilities. Lastly, still on GBV and disabilities, our structures under Health Center 4, we have a position of a social worker. But me as a district DCDO, a social worker at district level, I cannot handle equitably the roles of a social worker in a facility. It's a very big challenge.
Thank you so much.
Thank you.
I'm sure the role of the community development department has a big say in that area. And now that we're about to get to lunch, we can add our voices to his concerns, because I'm sure this forum may not.
I'm Dr. Chiria James, DHO Namutumba District. I just wanted my voice on the DCDO, how we intend to institutionalize CLM. Namutumba is one of the districts which has been selected to pilot in implementing Pillar 4 of the PDM. And when you look at Pillar 4, it is basically addressing access to social services like education, health, and environmental services. And this pillar is anchored at